The World Health Partners Sky case is a complex one involving a major American foundation working on public health in India. The project that was being implemented was an important one that sought to bring health services to rural areas in Bihar, one of the poorest states in India. The project fell short of expectations of its sponsors, though, and what we want to think about is what went wrong. When you read the case, you should think about the policy problem-solving framework that we presented earlier and how things might have gone differently had the foundation followed the guidelines in our framework. The World Health Partners Sky case illustrates the need to begin with a problem rather than with a solution. It opens with Smitha Shah, Executive Director of the Foundation's India office, trying to decide whether to renew a grant to World Health Partners, which had been trying to implement a novel, private sector-led project to bring health care to rural parts of Bihar, India. Bihar is one of the poorest states in India, with a Human Development Index well below the national average. There was only one healthcare provider and 0.4 doctors per thousand population in the state, leading to very poor child health outcomes in a region where 90% of the population lived in rural areas. There were 4 childhood diseases in particular that the project targeted. The protagonist in this case is a major American foundation that has been a world leader in improving public health in poor countries around the world. Located in Seattle, it has made billions of dollars of grants around the world combating a range of deadly diseases. The solution proposed by the foundation had 2 novel elements. The first, in line with the organization's background, was to make use of technology to provide health services in areas with few regular doctors. Since it was very hard to induce doctors to live and work in poor rural areas, health workers would be trained to connect doctors to rural patients through video conferencing. The second was to employ a social franchising model for service delivery. Some 70% of health workers in rural Bihar were not trained medical professionals, but so-called rural health providers, or RHPs. The quality of these health workers was often very low, which meant a great deal of distrust of them on the part of villagers. The social franchise model set up by World Health Partners Sky was designed to overcome these problems by providing a type of certification that would improve competence and therefore trust. WHP Sky would provide training, technology, and back-end services to which the RHPs could connect. This method was seen as a way of rapidly expanding access to health services throughout the state of Bihar. The social franchising model did not work out as expected. WHP originally set up a hub-and-spoke model where the RHPs were recruited to invest in facilities, the hubs, and then to recruit other providers, the spokes. They expected to sign up 20,000 franchisees, but it turned out that there were not enough hubs, which then failed to sign up a sufficient number of spokes. Recruiting the spokes directly also failed to yield a sufficient number of franchises. The final problem with this project lay in evaluation. The social franchise model had never been rigorously evaluated, so the foundation engaged an academic group to run a randomized test of the program's effect on ultimate health outcomes. But because the program was changed midstream, the evaluation group could not carry out a truly randomized test and reverted to a less rigorous methodology. That analysis showed that the introduction of the program had no measurable effect on child health outcomes for any of the 4 diseases that had been targeted. So we return to where we started. Should this project be continued? But perhaps we will learn more if we ask, could this project have been better designed from the start?